Welcome back. This is Ian Bodford.
And Liang Liu.
And welcome to the Clinical Correlation. Today's case is...
I just can't get enough. I just can't get enough.
Today's case is of a 35-day-old baby boy who presented with dehydration. The child was otherwise healthy and had been doing well at home until 1 week ago.
His mom had been feeding the child Similac Advance, and he was tolerating 4 ounces every 3 hours.
But then he started spitting up, initially just a little, and then seemingly all of his feeds for the last week. Mom has tried 6 different formulas and has even cut down on his feeds to 1 ounce every hour with no success.
He has also had decreased urine output, from 7 wet diapers a day to just 2 in the last 3 days.
He was seen at an outside hospital where workup was performed, including a reported normal abdominal ultrasound. He was given 2 normal saline boluses and transported to the local children's hospital. Here are his vitals. He is tachycardic, but really not all that impressive.
That story really is concerning. How did he look?
Not too bad, actually. He was a playful boy and really not in any discomfort.
Here's his weight plotted. If we zoom in, you can clearly see that he has fallen off his growth curve in the last week.
An ISTAT was ordered given his vitals, weight loss, and significant vomiting.
Looking at this gas, he is alkalotic based on the pH. This can be due to a respiratory or metabolic cause, or both. Given our patient's clinical story, a primary metabolic cause is most likely. However, even if you did not know the story, you will note that the normal range for PCO2 is 35 to 45, and his PCO2 of 47 does not fully account for his significant alkalosis. Additionally, his bicarb is 15 millimoles per liter above normal.
He is also noted to be hypokalemic and hypochloremic. Looks like no question he's been vomiting.
An abdominal ultrasound is performed and shown here.
So what are we looking at? If you see here, a tubular structure is shown with what appears to be very thick walls. This is the pylorus.
The pylorus is the outlet of the stomach, and typical measurements of the pylorus are shown here.
In our patient, his pylorus was 16.8 millimeters with a muscle thickness of 4.4 millimeters.
This confirmed our suspicion of pyloric stenosis. In the setting of pyloric stenosis, there is hypertrophy and hyperplasia of both the circular and longitudinal smooth muscle of the pylorus.
This causes narrowing of the gastric antrum, leading to a progressive gastric outlet obstruction.
The cause of pyloric stenosis is multifactorial and includes both environmental and hereditary factors. Classically, it is seen in the firstborn white males of Northern European ancestry. Approximately 95% of cases are diagnosed in those aged 3 to 12 weeks.
Recent cohort studies suggest bottle feeding and use of macrolide antibiotics, specifically azithromycin and erythromycin, were also associated with increased prevalence of pyloric stenosis.
Conventional teaching suggests, on an abdominal exam, you should palpate a firm, non-tender, olive-like mass. However, more likely will be signs of dehydration, which can include depressed fontanelles, dry mucous membranes, decreased tearing, poor skin turgor, and lethargy.
For this case, the child was given an additional 20 cc per kilo normal saline bolus, and then started on maintenance fluids of D5 half normal saline with 40 milliequivalents of potassium to replete his electrolytes. His magnesium was normal and did not require repletion.
Surgery was consulted, and he was taken to the OR for a pyloromyotomy. He did well and was tolerating feeds by hospital day 2 and discharged home on hospital day 3.
It can be scary to see an infant who has been vomiting. The red herring in this case was the reported normal ultrasound at an outside hospital. Also on the differential, as we waited for the ultrasound to return, were other causes of vomiting in an infant.
In well-appearing happy spitters, physiologic gastroesophageal reflux is common and is typically effortless regurgitation in an otherwise healthy infant. The symptoms typically improve in most infants during the first year of life and can be managed conservatively.
Infants can have other forms of intestinal obstruction as well, including intestinal atresia, Hirschsprung disease, malrotation with or without volvulus, and intussusception. If history is unclear, plain films of the abdomen and ultrasound can help distinguish between these cases.
In food protein-induced enteropathy, intolerance to dietary proteins typically manifests as colitis, presenting with bloody stools, but can present as enteritis with vomiting, diarrhea, and failure to thrive. A more severe form of this is food protein-induced enterocolitis syndrome, in which infants have profuse repetitive vomiting, often with diarrhea, leading to dehydration, weight loss, and failure to thrive. It is most commonly caused by cow's milk or soy protein, although other foods can be triggers.
Infants presenting with symptoms similar to those of pyloric stenosis, but with a hyponatremic hyperkalemic acidosis with disproportionate hypertension, should raise red flags for adrenal insufficiency. This is part of most states' newborn screening, so most infants, fortunately, will be diagnosed prior to developing adrenal crisis.
Speaking of newborn screening, inborn errors of metabolism are rare but life-threatening causes for vomiting in the infant. Each disorder presentation varies slightly, but generally they are characterized by vomiting, dehydration, lethargy, poor feeding, and altered mental status.
Lastly, in the infant with a full fontanelle and intractable vomiting, be on the lookout for potential non-accidental trauma.
To summarize, the classic patient with pyloric stenosis will have hypokalemic, hypochloremic, metabolic alkalosis.
Ultrasound is the imaging modality of choice for diagnosis.
ED management includes rehydration and repletion, followed by definitive surgical management.
And consider the zebras. Other causes of obstruction, food protein induced, adrenal insufficiency, inborn errors of metabolism, and non-accidental trauma. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com, and don't forget to follow me on Twitter @MDNotified.
Thanks for listening.